Good evening, everyone. Um, Thank you for making the time to get out here um, to get on this Zoom. I had the biggest problem getting on the Zoom, actually. Um, the agenda that I just sent out late um, was meant to just contextualize what the goal is here. My um, want um, from all of you is to get your perspective on what I joined the NCAA, the NAACP Health Committee to try to make some kind of progress on. It's stuff that all of us have talked, most folks on this call know each other. We've talked about these kinds of things for years. Um, so just to go over the committee's proposed purpose is fairly straightforward: to promote, protect, and maintain health of the residents of the county, to improve access to folks that are not as easily included, and tend to access the health services on an emergent basis rather than an ongoing basis. Advocate for that equal access and educate folks on how to get it. Because a lot of times folks just don't know how to approach it, so they show up to the emergency room because they don't have any other alternatives. And then to sponsor activities that um, show what it is we're trying to uh, realize in terms of goals, rather than make it a complex issue is didactic thing or a preachy thing, where we're trying to tell people what is good for you, which tends to fall on deaf ears, or at least create only transient enthusiasm. But to actually have outdoor gathering, hikes, outdoor events that address the goals. And so the objectives are to reduce disparities, on an ongoing basis, and promoting a healthy lifestyle, to lead by example, advocate for equity and access, and improve outcomes, which is a fairly elusive goal. The proposed event that I conceived of is fairly straightforward: just a hike, which is more a walk at Quiet Waters on June. Now I forget if it's 6th or 7th, but it's that Saturday. And the Physician Diversity Picnic is another proposal. Some of our members on this committee um, suggested other events that are taking shape, but they haven't, sort of fully formed as a concept yet. The invited guests, I overheard all of you introducing each other. For the sake of the folks that are either watching on the Zoom and may look at the recorded session later on, could we please just, folks, go around and introduce yourselves in terms of what you do, beginning with Heather Bagnall?
Sure. Thank you very much. I'm Delegate Heather Bagnall. I represent District 33C in Anne Arundel County, which is the Broadneck Peninsula and Severna Park. And I also serve as the subcommittee chair for the Public Health and Minority Health Disparities Subcommittee in the Health and Government Operations Committee.
Lisa?
I'm Lisa Rodbian. I serve District 6 on the Anne Arundel County Council, and that includes the entire city of Annapolis and then everything up and down the Annapolis Peninsula, from Arundel on the Bay and Bay Ridge, and then all the way up to Millersville. I just want to give a quick note that might be of interest to folks. Next week, the Anne Arundel County Council meets as the Board of Health, and we do that twice a year. So if there are things you would like us, we get a presentation from the county health department, and then we have an opportunity to ask questions. So if there are things that you would like us to be raising, we meaning me at the moment, and probably my colleagues too. But I'm happy to take your questions and bring back answers from our Board of Health meeting next week.
Please feel free to report, broadly on anything that we discuss here. But you see what the objectives and the presumed, the proposed deliverables. This hike proposed is a tangible initiative that we would love support on from any and all. And yeah, so thank you for mentioning that. If you could throw that in the chat, and I think it'll be captured, we can share it with the membership at large. And
If
President,
there's anyone that might be able to type on my behalf, I'm on my cell phone, so
okay. President
that would
Wadi
be
usually takes notes too, so hopefully he's receiving all this too.
The AI, thank God for the AI. So
Yeah. Okay.
we will,
I'll
but
just
no,
mention-
we have submitted testimony twice previously. So
I'll just say Pete Smith is hopefully going to be able to join us. He's County Council District 1. Rocio.
Thank you. My name is Rocio Ramirez Smith. I represent to the Office of Mayor Buckley. I am the new Hispanic liaison for the city. And although I'm new at the position, I have been working with the city, with the mayor's office for the past 2 years. So I am just getting familiar with the community now. I pretty much know all our partnerships and been working in their role in the backseat for a while. So I'm really happy to be here with you all today and to get to know you better.
Excellent. So if we could just go around and sort of reflect on how what I opened with is germane to the efforts that you're putting together now, and how you see how our objectives might take form and how we might collaborate at the delegate level, the county level, and at the city of Annapolis level, with these wants, with these objectives. And we'll start with Heather again.
Would it? Oh, go ahead.
Yeah, go ahead. What were you going to suggest?
I have a hard stop at 7 p.m. So I was going to ask if I might go out of order.
Oh, sure. Yeah. Go ahead. Go first.
Yeah. So we just are at the very beginning of the county budget process, and it starts with the county executive. But one of the things I think I'm really proud of is the expansion of our county health department over the course of the COVID crisis. A lot of that was funded with federal dollars. But the county has made an enormous effort to transition to county funding to keep a lot of those efforts going. So like important things like, especially in the health outreach, which I think touches on the including people and bringing people, connecting people with healthcare that are easily, I can't remember exactly how you said it, but easily not reached, or not always easily reached, and maybe rely, their health services often rely on emergency care rather than on regular care. So, I'm absolutely going to be supporting that in the budget, and I'm grateful that the county executive has and our budget office has worked to make that happen. So there will be zero decrease in the expansions that we've made at the county level over the course of, since COVID.
Is there a possibility, Lisa, that we could have the county health department attend the community hike, even if just to maybe put up a table and pass out flyers and make people aware that show up?
I think that is exactly the kind of thing that they would love to participate in. So if you, again, I'm sorry, you can see I'm in my car and I'm on my cell phone, but if you wouldn't mind even just shooting me an email, I will reach out to, our health director, or have her put me in touch with folks that are, that do outreach, and I can connect with them and, give me the details, and I'll try to make the connection. But I really think that's exactly the kind of event they would love to participate in.
Excellent. I don't know if there's anything else in terms of what you heard me present that kind of touches on anything else you're working on already. But it's obviously a great opportunity to do all the above. Educate, inform about access, and preventative care, which is really what we're talking about. And I find that this is something that I've done with several folks in the past, but unfortunately it happens in election cycles. There's enthusiasm for this kind of thing for a moment and then it disappears, which is parts of our community don't avail themselves of things like the health department, and feel like, either an emergency room or an urgent care clinic are the only places they can get care, when in fact they can get a lot of preventive care at the county, but they're not taking advantage of those resources. And part of it is just, um, maybe distrust or lack of experience with it. And another is just distance. Maybe the locations of the various centers aren't really where people go for care. So things to keep in mind, I guess. Let me jump back in, but I just want to go around and get everyone's thoughts on where they see it coming from. So Heather, again.
Well, thank you. And I've been sitting here jotting down notes because, of course, what a lot of what we do is policy at the state level, but we also do a lot of funding and community initiatives. So I think there's a real nexus with what you're trying to do, and the role of the state, because when we're talking about preventative care, when we're talking about public health, we're often looking at how we make it affordable, how we make it accessible, and how we make it equitable. And that's, ongoing work. And we even have a commission on public health now, which is in our second year of what will be ultimately 3 years of work to try and look at our existing healthcare system, how we can improve it, what we've, lessons learned in preparation for the future. And there are four sort of pillars that we're constantly looking at, and it's infrastructure, workforce, interoperability across not just our state agencies, but working with the local, working with our federal partners, and particularly working with those local health departments. And how do we make sure that these resources are getting into the communities as intended, and funding. So when we're talking about an event like you were speaking to, I feel like that's an opportunity not only for us to bring resources, but also to have those conversations with the communities as to what that disconnect is. If they're not getting into preventative care, if they're not getting those collaborative care models in their communities, what are the barriers? Because we've got lots of data as to what the statewide barriers are, but this is an opportunity for us to really get at the granular level so that we're making sure that we are pushing those resources into the communities as needed, and also addressing the right barriers, right? Like, we can have all the data in the world, but if our initial hypothesis is wrong, then we're not seeking the solutions that actually solve the problems. So I think there's an opportunity there for us to bring resources to make sure people know what is available to them, but also for us to hear from the communities as to what they are seeing as barriers to that access.
Thank you for that. Rocio, can you give us your take from the city, at the city level?
Yeah, so what comes to my head right away is our Office of Community Services. They have great programs that help with giving grants, and also for as long as they have the funds, they also help with rent. If that doesn't really relate directly with help with healthcare, it does help with other things that people can need while they end their procedures, or they are being put away, or they're just unable to pay their rent or the electric bill for the time that they are in medical health care. It is an option that the city has for people that need that help. So it's an office that I would like to connect you with as well. Our manager is Aisha Young. She's been doing wonderful at the position too, and trying to help and giving a lot of resources, or at least educating the community about the resources available to every city resident.
One couple of things with the commentary about first of all, at the county level, the one frustration that I have with the way the system manifests is that the health for the county has great programs. There are sort of resources on that website that don't translate to what people actually access, particularly in terms of mental health. There are people actually in the NAACP. We've had meetings where they've said, where are these resources? I direct them to the website, and it's kind of hard. You have to go through a couple of different paths to get to the right link, and I don't think everyone is just as easily you know, has that kind of ease of use, and somehow it can be made more obvious because the fact that it's not obvious, and when people are in sort of an urgent situation, they tend to panic and say, "Well, there are no resources," but actually there are ongoing resources. You're just not accessing them. So, do you have any thoughts about how do we fix that?
I think we need to take that commentary to the health department and let them know that that's feedback that they need to hear. I'm so sorry that I have to go, but I've hit my hard stop, and I'm a speaker at an event. But I know that we have tried to meet in the past, but I'm happy to try, to come again in June or July and August to, make sure we have a complete conversation. But also, please, thank you, and thank you for inviting me. So I will be sure to take that very specific question on, I believe it's our Board of Health meeting is on Tuesday, but please email me with any other thoughts, or if you want to, I don't know what kind of, network, social media, or email listservs, if you have things that, you want to just say, hey, what questions do you want a council person to take to the, to the health department? And that one will be on my list.
Thank you. We will take your word and get the info to you. Thanks
All right,
very much for taking the time.
Okay, bye.
So Heather, I'm gonna sort of have a similar question or proposal with regard to the program. The idea of energy for funding efforts, say with community groups like the NAACP. What specifically can be carved out, and this would be probably a better conversation to have directly with President Wadi, with regard to how do we create a resource, a source of support for a proposal like maybe the one I just made. Obviously, the one I just made is really a zero revenue proposition, but there are many other initiatives and wants and asks that we always struggle with because there's a limited budget at the NAACP for the county chapter. Is there a way to create a path to connecting those dots?
So I think what you're asking about is like grant funding for specific initiatives. Is that what you're talking about?
Pretty much. I think that there is a series of different, Sky, who's going to jump on the call in a couple minutes probably, also has a proposal around mental health and wellness would be, I think, very appropriate place to put that kind of resource.
So
But
there's
how do we become connected to it directly?
so I can connect you. There's a couple of different paths depending on what it is you're looking to do. There's the Maryland Community Health Resources Commission. They actually do community health grants. And we can I can connect you, and you can work directly. There's the Office of Minority Health, but they don't do as much in terms of funding. They're looking more at the health equity framework. But also coming online, you may be aware that that we're transitioning now from the total cost of care model, which is that shared charity care across all of our hospital systems, and they also have community health grants through the hospitals, or community benefits grants, sorry. But we're transitioning to the AHEAD model, which is an all-payer model. It's very similar to what we're already doing in Maryland, but it's the new federal program, and that still has those community resource grants, but there are very specific pillars for those grant monies. And again, it's about making sure that those funds are going into the communities. So I'm happy to connect you with all of those resources. And then if you're talking about behavioral health, then we have the Behavioral Health Administration, and they do some of the grants that they do are through like SAMHSA and through Medicaid. Now, some of that funding, as I'm sure you can imagine, is a little uncertain going forward. But we do know that we do have these grants funds that are available, and they're meant to do exactly what you said, to look at disparities within communities and strategically targeting funding to address those health disparities. Uh, the community resource grants tend to follow certain pillars, but we have other grants fundings that are specifically targeted at making sure the monies going into the community are addressing the needs of that community.
Well, let's go to that for a minute. Sorry to interrupt, but precisely that. So I've worked within the emergency medicine system at the University of Maryland and MedStar and Hopkins. So the problem becomes that their systems are meant to fill the box, but they become disconnected from folks actually growing an understanding of how to use the system and or really improving their access, right? So these types of disconnects are the problem, I think, between sort of the profit-driven hospitals and deliverables to the community. So this is what I find. This is why I'm actually on this call. So you know, as an example, emergency departments and urgent cares are not designed to address these kinds of problems. They're designed to sporadically treat, and so it becomes a matter of, well, you use funding that um, that is designated for these purposes to subsidize those episodic care events. And so the entities correctly cite that they are you know dipping into funds that are made for this purpose, but however they're the most inefficient use that they could possibly be, and all it does is fund a model that's perpetuating itself, that's not actually addressing the problem. I don't know if I'm making myself clear, but it becomes
You are, and this
problem.
is one of the reasons that that the feds pivoted somewhat for the AHEAD model, because it does require that those funds go into the community, that they leave the hospital. They, you know, that to your point, that is the main flaw of the total cost of care model, is that it becomes much too discretionary for the hospital. And and I think there is a concern that they're not necessarily identifying. And I think this is also a challenge with block grants in general, is that often you will identify an issue that has funding rather than identify the need of the community and then push the funding to address that need. And that
Yeah.
is, I will be honest, that is a constant challenge. And one of the things that we did this year, that was actually my bill, in an attempt to address that, was creating a framework for a memorandum of understanding for hospitals, community-based organizations, and community health workers, to make sure that the workers were first of all, you know, they were having uh, uh, you know, adequate reimbursement, and, you know, who was the supervisor, who was the employer, make sure that that transition between CBOs and hospitals is is clean and succinct, but also making sure that those community-based organizations could also apply for and access those funds, so that, again, they're the ones who are sort of on the ground, seeing the need and hearing from the communities. So they really need to be the impetus for those initiatives and the recipients of that funding.
Right. So let me see if I can put this in a lot more succinct and eloquent way, because I think I overgeneralized the first time I stated it. The model of a profit-driven hospital to participate in global budget will only shift the way in which the budget is allotted. It will maybe encourage them to, for instance, cut budgets and make changes that create efficiency that would then extend the inpatient or outpatient services overall budget. But this is not the same as creating more access. This is just making the system is encouraging a more efficient use of resources from government sources, but it is not promoting a decrease and an overall efficiency of usage. So for instance, it's a little complicated, but the hospital doesn't make money unless it's providing care in the hospital. That is probably the least efficient way to get care. The money doesn't go to primary caretakers. We have a dearth of primary caretakers. We have a huge need for culturally concordant providers, right? So if you go to PG County, you find Black and Hispanic doctors. It's very hard. It's very rare, especially, you know, physicians of color in general, in Anne Arundel County. This has been the truth for decades. Everyone that studied it has stated, well, people don't, you know, take their practice here for a number of reasons. Well, those reasons haven't changed, and the hospitals that hold themselves up as, you know, having this as a goal are not reflecting that. Decade after decade, they're not reflecting that in their staffing, in the leadership, in the boardroom, in the C-suite, in just primary caretakers. It's not easy to find Black primary caretakers in this county, and nothing is incentivizing that in the AHEAD model. You know, nothing is actually creating that.
Well,
Dr. Gomez,
the-
Dr. Gomez, can I hear Delegate Wagner respond to that real quick?
Yeah.
Well, I was going to say I was responding to your initial question. So when we talk about the AHEAD model, you're correct. It's nothing is incentivizing changing the workforce in that model, because that's not what that model is designed to do. We do have other efforts, because you're right, the workforce is not reflective of the community. And there are a lot of things that we're trying to do, and one of the biggest issues one of the biggest barriers we come up against is it particularly in the Medicaid space is reimbursement. But even in primary care, we struggle. Even in our educational spaces, we're struggling to build this workforce, because the reimbursement rates have not kept up. The tuition reimbursement is not equal to the debt ratio. And all of these are very real problems that do not have easy and clear solutions, but they are somewhat independent of when we're talking about the AHEAD model. Because I just want to be clear about that, because that's just one piece of the larger puzzle.
Okay, I agree.
And part of what we're trying to do is also make sure that we don't have regulatory burden, that we have effective and efficient licensure processes, that we have compact agreements so that people can be a little more mobile, that we have the collaborative care model that's now reimbursed through Medicaid, so that you can have your behavioral health care in your primary care. And we have Maryland Primary Care, which is an initiative to try and expand primary care, because we haven't invested in it. The state of Maryland hasn't invested in primary care, and neither have we nationally. So we haven't built an adequate bench for the needs. And we know that. In fact, one of the things that I did a couple of years ago is I passed a behavioral health workforce trust fund. And the first piece of that was an assessment, a needs assessment, so that we could, again, be strategic with our funding. And the needs assessment said that we were at 50% of staffing for where we would need to be for the need by 2030. Now that's shocking.
Well,
And it's not something that has an easy or clear solution. But it is a priority, because it's a problem that we have to solve, and we have to also make sure that young people who are considering where they want to go in the workforce are seeing people who look like them in these positions. And um, that is a long-term challenge with no clear solutions, because we haven't built that bench.
so thank you for that. Number one, the taking the investment in the area in the direction of primary care is a fundamental.
Yeah.
You know, I because I'm so close to it, it makes me impatient, because this is not news. It's just been that way for like 50 years, and unfortunately, every time we sit, you sit at the table with allotting significant funds or making decisions with regard to reimbursement or such, there are huge shifts, and the shifts are being dominated by folks with credibility, which are usually the gigantic hospital systems that are making money on interventions. And they talk a good game about primary care, but they really are not creating that. They're not expanding that. And so more and more patients are actually accessing care through say, urgent care or the emergency department more and more all of the time, even though these systems are supposedly, you're bending the ear of folks with the larger budgets. They are still, the profit-driven entities are making decisions based on how they maximize return to their investors, and that's that's a how do I say, that's a bigger problem. It becomes, the global hospital budget becomes more a goal about how do you maintain the margin than how do you shift the resources. Because truly, if you, and I've said this many times and in different forums, truly, if you prevent enough care, you will reduce profit for hospital systems. And they know this. So it becomes a difficult thing to say, well, yeah, I'm going to invest in something that's actually going to reduce my profit margin. So from the business side, it's not, this is why I say, how do you involve not just the NAACP, but any community group that would be able to say, well, this is where, uh, you know, staffing a clinic in the community, that would be a way to expand primary care. If the budget were to go to the health department and the health department were to provide the clinical services, hiring clinicians to actually do the work that patients need, then we'd be actually addressing primary care, preventative care, and giving access because you're creating the resource where people need it or use it.
Do you find, hold on, Dr. Gomez, let me hear Delegate Bagnall respond to that.
Yep.
Well, and have we lost Rocio?
I think so. She got off at 7 o'clock.
Okay, I'm sorry. Well, so I guess I'm trying to figure out what your question was. How do we involve organizations, or
Not how we involve organizations, but why we don't look at what the goal is and make resources available for that purpose. The public health department is, I think, a reasonable place to put the resource if they're getting a budget that allows them to staff a clinic. Like there are subsidized care clinic that are run by Anne Arundel Community, Luminous Health now. And if such a clinic has been in existence for years, say on Clay Street, at the I forgot the name of the building, but it's a way to directly benefit the local community with primary care resources. But if you take the budget and you say, here, hospital, responsibly, use this and try to hold their budgets accountable to reimbursement, that doesn't work. It just doesn't work. It doesn't work because there's conflicting interests. That's what I'm saying.
Okay, I guess I'm a little confused because it sounds like you're saying that the entire budget is going through the hospital system, and it's not. And part of what we're trying to do, part of the charge of the Commission on Public Health is to figure out how we, to your point, how we get those dollars into our communities, how we get them into primary care. The global budget and the total cost of care and the AHEAD model, all of those are looking at how we fund our hospitals, and there are community benefit, there are community resource grants as part of that. But our hospitals, I know they're nonprofits, and that's a bit of a misnomer, but we still set their rates. You know, the state of Maryland still sets their rates, and we do still have funds that go to our local health departments, to our behavioral health, to our community grants through the health grants. We do have funding that go to specific initiatives. So I I agree that I will say this. I think the hospital association has too much influence over some of the decisions that are made. But the hospitals don't have the hospitals don't have control of the budget as such. So I guess I'm trying to understand if you're saying like don't fund the hospitals, fund primary care, or what the ask is. I'm just not clear on what the ask is.
Not quite. I suppose what I'm really saying, and I don't disagree with what you're saying. I understand we're not talking about taking a budget and just saying, here, turning over funds to you for your decision on what you think is prudent investment in the community. But to hold them accountable for the way in which the system, the CMS reimburses, right, is very difficult to control because they're reimbursing for services which may not be in the best interest of this goal, is where
Okay.
I'm coming
Gotcha.
from, right? And so, granted, of course, there is a budget to the health department, and they use it as they deem fit. I think what I'm trying to get at is, in order to sort of cut out the middleman and get closer to the communities where the deliverables are going to be realized, that's what I'm trying to conceive of. And again, I know that the AHEAD model is a lot more sort of comprehensive. The
And
community.
it makes more
Community-
demands. It
Yeah,
makes
but
more demands on
right.
demonstrating those health equity um um uh improvements in progress.
Right, but to
Or
say that,
I don't think we really were doing that adequately before. And we have the same, we also have that with our MCOs. Like there are health metrics that they have to meet. And I will say it is part of the job of the General Assembly to hold them accountable, because I don't think that the executive necessarily holds them accountable, or at least the previous administration did not hold them accountable in a meaningful way. It was like they reported the data and nobody ever looked at it. And they reported the data and nobody ever looked at it.
right.
And when the data was not demonstrating that we were getting the progress that we were expecting, then there still was not there was not like an enforcement or accountability effort the way that I think there should have been.
Stephen.
So we just heard from Councilwoman Ravian about the Board of Health, the county council sitting as the Board of Health. Should we follow up on this discussion that you're having about bills that were recently passed that are being implemented at the local level through the county health department within our testimony that we sent to them?
Are you asking me or
I'm
Delegate
asking
Bagnall?
Delegate Bagnall. I'm, in terms of the bills that are going to be implemented locally, that
Mhm.
we have to be the ones to follow up with them on, because
Oh, I see what you're saying. Okay.
I don't expect, like, the police department is supposed to implement the police accountability board, not the police department, but the county is supposed to implement the police accountability board. They're supposed to train police officers to do certain things. But we, as the NAACP, have to be the people who say, did you all do this training? How successful was it? you know, are you still arresting children and making them be interrogated without their parent? You know, like those are the things that we have to do as the NAACP. So in implementing this new model of you know, or implementing this anything from the county to from the state to the county public health department, or within Luminous or any other, you know, hospital association that we're talking about. Um, uh, what should we be looking for advocacy wise to be able to address them with? That's kind of where my question is.
So if you're talking about specific bills, I'm happy to give you those specific bills. But to your point, yes, it's worth having the conversation. Now, the bills that we just passed won't be implemented till October or June or July or October. But it's always worth asking the question. In fact, that's something that our committee has started doing is you know, especially our chair is asking, like, where are we on implementation? You know, we passed the assisted outpatient treatment last year. It took 23 years to pass. This is a great example. It took, you know, we were one of the last 3 states that didn't have an assisted outpatient treatment program. Then we came to find out that very little progress had been made on actually implementing it.
Yes,
So, you know,
yes,
the devil's
that
in
is
the
the point.
details, making sure that that the relevant stakeholders are meeting, that the regulations are getting written, that the money is flowing to the local health departments, that the local health departments actually you know, have an implementation plan, because a lot of times these, you know, these state legislation still gives local health departments and local behavioral health authorities a lot of flexibility as to how to implement it, because obviously, you know, different regions have different resources. Um, but
Thank you for bringing that up.
it's
That's
always,
exactly my point.
yeah,
That's exactly my point. The implementation becomes lost. Like when you say you know, connecting community resources to to things like socioeconomic determinants of health and housing and transportation, that becomes so huge that's
right.
impossible to address that, right? So it's a want that's like very lofty, but it's not connected to something very simple, which is primary care provision, period. And if you sort of bundle it in programs like Ahead, then it becomes lost. So I think Stephen Waddy helped uh, sort of clarify my point. Accountability requires some sort of tangible, visible connection to the thing you're trying to accomplish. So if you don't have primary care doctors in areas where people are going to access them, then they're going to go to the urgent cares or they're going to go to the emergency departments, period. And if there can be a way, not just for oversight, I think in the case of the NAACP, we're like, that's our thing. Like we take feedback and we say, this is what is not happening. I suppose that a number of similar health advocacy groups around the state and around the country could have similar roles. To be included in that process is key. So thank you,
I'm, I,
President Whiting.
I know I don't know if you were finished, but the other side that I want to add is the race conscious aspect of it. Because I want to make sure that we discuss if there are any race conscious um, uh, accountability measures in these bills or in these state mandates that are being put on the counties in what you've passed already in terms of hiring of physicians, as Dr. Gomez has stated, and also in the provision of resources to particular races or ethnicities and or particular zip codes that might be um, uh, majority minority.
And if I could just sneak in one other ask, but by bilingual caretakers, like really bilingual caretakers, not that you're Spanish, not not I speak un poco español, but actual fully fluent folks, because I can't tell you how consistent it is that patients come in with a complaint. They'll take a minor addressing of their concern over nothing, but they're not really getting their needs met because this isn't like required. It's not a requirement. It's always thought of as a kind of a bonus if you can get some individual providing bilingual care. All right, I'll get off my soapbox. Sorry.
Well, and again, I go back to what I said before. We're actively recruiting, but the bench isn't necessarily there. So, you know, while we are attracting and requiring it and creating these requirements, we also have to make sure that we're not eliminating our existing workforce, which is always the balance. But we now have like plain language requirements. We have multilingual requirements. We have language line requirements. We are one of the things that we're talking about, even with the Commission on Public Health, is coordinators to try and connect people, because one of the biggest challenges is simply connecting people to the existing resources. They don't know about them. They don't know where to go to look. And a lot of times people, they don't necessarily want to ask either. Nobody wants to say like, I don't know how to navigate this website. I don't know where to look for, for a primary care provider. We have to make sure that that even our database of providers that accept your insurance is up to date, because often that is a huge barrier, is that you identify somebody that accepts your insurance or accepts Medicaid, and they're no longer accepting those patients, or they're no longer accepting new patients, or they're no longer even practicing. And so we had legislation to require that those lists be made current. And I think that the more people we have helping us um, pass meaningful legislation, but also hold us accountable to getting it done, the better, because we really do. I mean, I'm still in meetings on AOT to make sure that it actually happens. I'm still in meetings on the pediatric overstays bill to make sure it happens. Like, we still do follow up, that we're not doing that work just in 90 days. But kind of the more eyes that are on it, yeah, the better. I mean, I don't think there's any of us that are resistant to that, because to your point, Dr. Gomez, some of these are just so big, we can't have eyes in every zip code.
Yeah, well, I thank you. We got a little bit over. I can't tell you how useful this conversation is in terms of understanding what we're up against, and I think we're beginning to have thoughts about how how to create less disconnect between the intent and the want. And before we get off, I just want to also say hi to Sky, who finally made it onto the call, and ask if she had anything she wanted to add.
Was that addressed to me, Ellie?
Yeah, I was inviting you to participate and just.
I'm sorry, I'm on mute because I'm in a store, so I was listening, but I'm trying to just over in the corner right now, so you don't hear too much noise.
Okay.
But no, I don't have anything to say. Thank you.
All right. So in closing, I would say let's sort of be aware maybe more about what's happening at the state level. Heather, if you could somehow send us an update to share with the membership, that would be hugely helpful. Or whatever it is that is sort of already packaged up that you're working on. Not that you have to draft a new statement for us or anything.
Well, and if I could ask you to just give me a little time, because I'm still in England. So
Oh, wow. Yeah, that's right.
it's currently 20 of 1.
Tally ho.
But I'll be back. I'll be back on the 13th. So I'll be, back and fully back to work. And so maybe a little more cogent. I apologize that I'm still a little um jet lagged. But yeah, no, and I will tell you, one of the things that I wanted to mention, I know we're over time, but I wanted to mention this just because we did it. we did we did a presentation for the Prince George's County Council at their request. Last year, we had a panel discussion, and it was really, really great and very meaningful. And the whole community came out, and we at the state level presented everything that we were doing in maternal health and mental health and the nexus between the two, because particularly women who are uh in the have just delivered within that first year. They're very vulnerable to heart issues and postpartum. And so we did a presentation about what we were doing, but also what resources were available. And it was, and the county council didn't know. And then the community came in with questions, and also with statements about the barriers that they were experiencing, which helped inform both the state and the county on how we could partner better. So if there's
Wow.
ever a specific initiative that you would like us to come in and address and do an address for the county council, we're happy to do that.
Well, then let's do that. Let's plan to do that specifically at a meeting in after you get back and after there's time to sort of plan that.
And
And
let's talk about the community-based organizations in the primary care.
exactly, and focus it in that direction, whether at a NAACP meeting or at a separate event that's specifically for this purpose, so that we could have a similar turnout and folks asking questions here in the county. What do you think, Stephen? Stephen, you still there? Can you hear me?
I'm here. Yes, totally.
Okay. Well, with that, why don't we close it up? And we've kept Heather awake long enough. And
And I can coordinate that with the local health department too.
excellent. All right. Well, thank you all for taking the time to have this conversation, and hopefully it'll be shared broadly, and we'll start getting inertia to make this thing happen.
All right. And thank you so much. And like I said, just give me a couple of days, and I'll have something fairly comprehensive for you, because like my end of session letter it's not totally on healthcare. So I'd like to do the comprehensive, this is what we did in the health space.
Can I ask you, is there a particular series of letters that we should look to in order to get your position on some of these things? Or
Oh, well, I mean, I can send you my end of session letter, which is it's an overview of sort of a lot of the priority legislation, but it's not just focused on health. I mean,
okay, do you have any minority health or like
Mhm.
minority health related?
Yeah, I'll
information?
send you everything that came through my subcommittee, because I'm the Public Health and Minority Health Disparities Subcommittee.
Yeah,
And
perfect.
if it came through my subcommittee that I supported it. Um because I made sure it made it out of subcommittee.
Right.
But yeah, we had a lot of good legislation that was trying to make things more efficient, more equitable. Obviously this year with our financial landscape, we didn't have a lot of money, but we leveraged it well, I will say. Given the challenges of this session, a lot of really good work still came out of the Health and Government Operations Committee.
Are there any minority health advocates that you would point us towards that come to speak before your committee consistently, or?
Yeah, and I can compile a list, because we've got quite a few groups that come before, and minority groups that come before us and advocate on a lot of this legislation.
Wow, I would love to invite a spokesman for us to listen to in these meetings too, and learn from them too, how they're seeing it.
And I will say I'm happy to be here, but the expert is Jocelyn Pena Melnick.
Yeah.
Because this has been such a priority of hers for her and her entire time in the General Assembly. And so as chair of the Health Committee, she really centers equity in all of our work
I will
in
reach out to
a
her
very,
too.
very, very meaningful way.
Thanks for that reminder. I'll reach out to her.
But I'm making a list of my homework. So
All right, folks. So we're going to meet again.
get all of that to you by middle of May. So
Excellent.
Thank
All right.
you. Thank you so much.
Thank you,
you're very
everybody.
welcome.
Thank
you,
you.
everyone. Thank you for the invitation.
Thank
All
you.
right. Thanks. Bye.
Antonio. In the meeting.